The problem that this client has is knee valgus. This is where we see the knee drop inward. We've determined that the assessments to conduct would be a gait treadmill walking test first, and an overhead squat assessment as well. Here we see the treadmill walking test, and the subject demonstrates this inward knee drop on their right leg. This is best seen from an anterior point of view. In this picture, we see a squat assessment with the normal position and then the knee valgus. Here it is in action with the subject demonstrating their right leg with the knee valgus moving inward. This shows that muscle weakness, which allows the knee to drop in and is not ideal. Based on these assessments and according to NASM, probable underactive muscles will be the medial hamstring complex, medial gastrocnemius, gluteus medius/maximus, vastus medialis oblique, anterior tibialis, and posterior tibialis. And the probable overactive muscles will be the adductor complex, the biceps femoris short head, the tensor fasciae latae, lateral gastrocnemius, and vastus lateralis. To better determine what is particularly limited on our client, we must conduct a few range of motion tests with a goniometer to determine if they're at normal ranges. Based on their knee valgus, we've determined to do a hip abduction and knee extension tests. This picture demonstrates the start position for the knee extension. To conduct the knee extension range of motion test, the client is supine with 90 degrees of flexion at the hip and knee. For the axis of rotation of the goniometer, it will be at the lateral joint line of the tibiofemoral joint. The stationary arm will be at the lateral midline of the femur, and the moment arm will be at the lateral midline of the fibula. The subject is demonstrating a normal range of motion at 20 degrees, but our client with knee valgus only has 14 degrees. Next, we will demonstrate hip abduction. The client will be supine with their knee extended and their hip neutral. The goniometer axis of rotation will be at the anterior superior iliac spine, or ASIS. The stationary arm will be at the imaginary line from one ASIS to the other across the body, and the moment arm will be at the anterior midline of the femur, referencing the patellar midline. The subject here demonstrates a normal range of motion of 40 degrees, but unfortunately our client with knee valgus only has 25 degrees of hip abduction. After conducting the range of motion tests, we move on to conduct manual muscle tests to determine weakness in muscles. For this particular client, we've decided on the medial hamstring complex and the gluteus medius. These two muscles are both typically underactive when the knee valgus is an issue. For the gluteus medius, the client lies on their side with the hip slightly extended and the knee extended. The tester supports the hip, applies gradual increasing pressure to the leg in the direction of hip flexion and adduction, and instructs the client to hold a position. They would receive a grade of 1 for weakness, 2 for compensation, and 3 for normal strength. Here the subject shows both normal strength and then that weakness. The next manual muscle test conducted is the medial hamstring complex. For this one, the client lies prone with the knee flexed at 90 degrees and the foot internally rotated. The tester stabilizes the hip while pushing the leg into knee extension. They instruct the client to hold the position. And again, they would receive a 1 for weakness, 2 for compensation, and 3 for normal strength. And the subject shows normal strength and then also weakness in that last picture. Now that range of motion and muscle weakness have been determined, we apply the corrective exercise continuum, which is a systematic plan. This is used to describe the process of identifying neuromusculoskeletal dysfunction, developing a plan of action, and implementing integrated corrective strategies. Our client is currently experiencing tightness in the tensor fasciae latae biceps femoris short head, and the adductor complex. These are all commonly overactive and can be tight as a result. We start with the tensor fasciae latae, the first step in the corrective exercise continuum, which is inhibit. We'll use self-myofascial release, or SMR, which is a flexibility technique used to inhibit overactive muscles. The goal of SMR is soft tissue mobilization and reestablishing neuromuscular efficiency in the body. This should release the tightness the client is experiencing. You will roll and hold on the tight areas for about 30 seconds. Moving on to the short head of the biceps femoris. The client is here shown rolling that out. Typically, you would roll it again for about 30 seconds and hold it on that tightness. The last step for this client in self-myofascial release is for the adductor complex pictured here. The client is seen here demonstrating rolling out the adductor complex. The adductor complex can be difficult to pinpoint since it is a small area, so it can be performed with smaller foam rolls or tennis balls, which can better pinpoint the trigger points of the tightness. Although not demonstrated, once the client is finished rolling the area, the foam roll should be held in position for about 30 seconds. The next step in the corrective exercise continuum is the second step, lengthen, which is in the form of static stretching. This will increase the extensibility and range of motion and also reduce injury. The first one pictured is the supine biceps femoris stretch. The client will lie supine with the knee extended and the leg adducted across the body, grasping with the opposite hand to stretch. The next stretch, the standing adductor complex stretch, the client will stand with one knee flexed and the other extended in a lateral lunge type position. Each stretch should be performed about 20 to 30 seconds, 60 seconds for older adults, and performed a total of between 1 and 4 times. Now that the overactive tight muscles have been addressed, we focus on the client's weak muscles. This third step is activate. This increases the intramuscular coordination of specific muscles and re-educates underactive tissues. This is done by isolated strengthening. Shown here is the medial hamstring leg curl used with a pulley, and the foot is abducted to better activate the medial hamstrings. Next is the standing gluteus medius leg adduction with a pulley. The beginning stance is with the leg being activated, crossing the other. These exercises should be performed 3 to 5 days a week, 10 to 15 repetitions, and 1 to 2 sets. Optimally, there should be a 2-second isometric hold and a 4-second eccentric contraction. The last step in the corrective exercise continuum is integrate. This focuses on multi-joint stabilization and mobilization, as well as retraining synergistic function. These will be in the form of dynamic total body exercises. These have a low load, controlled movement, and ideal posture. Shown here by the subject is a lateral walk with a resistance band just above the knees. Demonstrated here is the ball squat with resistance band, again just above the knees. The resistance band is placed above the knees in both integrative movements to ensure that the client is not allowing the knees to drop in. Here's the anterior view. Each should be performed 3 to 5 days a week, 10 to 15 repetitions, and 1 to 3 sets, slow and controlled movements. This process of applying the corrective exercise continuum to the client with knee valgus will help them achieve knee balance. As seen, this is made possible by inhibiting, lengthening, activating, and integrating the under and overactive muscles causing the client's knee valgus.